think we have several folks flying through cyberspace here joining us. Thank you so much for being here today for our second ECHO session of 2024. We're thrilled to be here today talking about increasing oral health access through innovative programs. Have a really exciting program to share here with you today. So we can head to the next slide and get started. Well, welcome. We'll start off with a welcome, some housekeeping and call overview pieces. I'm Liz Flannery. I'm the Director of Education and Leadership here at I-RDH. And then I'm going to hand it off to Monica McKee to give us our didactic presentation on increasing oral health access through innovation and value-based care. We'll have some time for some Q&A, and then we're going to have a very interactive, collaborative action community discussion to finish off today. We want to take a minute to thank our partners, UNLV, Southern Plains Tribal Health Board, NRHA, and OPEN. You can head to the next slide. So just some housekeeping for our time here today. We are recording this session. We will have this recording as well as other session materials available on our website after the call. Please avoid any patient health information. Take a moment now to introduce yourself, type your name, your email, your organization in the chat, and say hello. Again, this is going to be an interactive session today, and we'll really get to work together and know each other as we go through our time here, specifically at the end with our discussion. If you're having any questions about Zoom or technical issues, please pop them in the chat. We have our staff from I-RDH here today, and we can help you out. So to start us off, we'll give a little bit of information about I-RDH. Our mission is empowering our community to advance oral health through science, education, and advocacy, like this educational programming that we're doing here today. Hopefully this brings good information to you in your role in your community. And we're doing this work towards a justice-oriented oral health system. You can head to the next slide. We have 4 communities of focus here at I-RDH. It includes LGBTQIA+ people, veterans, people with disabilities, and people living in rural communities. Obviously, we're talking about a topic with a rural focus here today, but also we want to recognize that there is, of course, a lot of intersectionality among these communities as well as other groups. These are our communities of focus because these are communities who have been historically excluded and underserved, particularly when it comes to oral health. We can head to the next slide. So we talked a little bit of our mission. Part of the way we achieve that is through the work with our education team, and we have a variety of types of educational programming, running from a standalone or series of webinars or workshops, moving on to learning collaboratives, which are groups on a dedicated topic, certificate programs like this ECHO program, where we have a dedicated curriculum and a pathway to earning a certificate, which can signal expertise in an established topic. We have even more robust programming, fellowship-based programming, which are applicant and cohort-based, and all the way up to our in-person annual conference, which is our colloquium. And this is so that we really strive to make sure that we have something for everyone on the professional development pathway. And again, bringing education to the oral health workforce to really achieve that mission of working towards oral health equity and justice. We can head to the next slide. So a little bit about our ECHO model. We're really bringing subject matter expertise like Monica together in a group to kind of, we do this in a virtual manner to expand the reach and really kind of bring expertise into a wide variety of communities. You can head to the next slide. So a little bit of the norms that we practice when we're in these sessions. We follow an all teach, all learn model, recognizing that everyone has something to contribute. So again, we have a subject matter expert with a didactic presentation, but we'll have a very collaborative group conversation, leveraging everyone's expertise all together. We use first names to facilitate equality in the discussion. We invite you to add your pronouns to your Zoom name. And if you're sharing, speaking, please introduce yourself with your name, organization, and location. We invite you to turn on your video, but keep yourself on mute, again, particularly with the discussion session, and just being respectful and working towards a respectful environment during our time here today. You can go to the next slide. Our theme for our 2024 ECHO series is navigating rural and tribal oral health solutions using a community compass. So we're doing this to explore key assets of rural and tribal communities and how to advance oral health access through community engagement. It's building on our ECHO session from last year, which was looking at innovations in rural oral health, but that's certainly not a prerequisite. That information is all recorded and available to go through asynchronously if you didn't attend the sessions live last year. And doing that, you can also earn the certificate that we had available last year. There are CEUs available for each ECHO session. After completing an evaluation and a request form, we'll share more information on that at the end of the session. It's required to attend the entire session for that CEU. And we also will be offering a certificate in community engagement and rural and tribal oral health after completing competency assessments after the sessions. We'll share more information about that via email. You can head to the next slide. So again, this is just our list of the series we have planned for this year. We're on second of 5 ECHO sessions. We're thrilled to be here, and we encourage you to look forward to our additional sessions, and we'll share registration information for those as well. Go to the next slide. These are our learning objectives today. These tie to our CEUs and are also available in our registration information of what Monica will be leading us through today. Go to the next slide. We don't have any disclosures from our speakers today. We can go to the next slide. So with that, I'm going to hand it over to Monica. Just share quickly the expertise she brings with her today. Monica is the Vice President of Allied Services at the Oklahoma City Indian Clinic, which is the nation's largest urban Indian healthcare facility. And we are talking about rural communities today, but again, Monica is going to share her program with us and really kind of those pieces where there's that overlap and where it can really meet those overlapping needs that are seen in urban settings as well. So with administrative oversight encompassing dental, optometry, behavioral health, and physical therapy departments, Monica plays a pivotal role in upholding the clinic's commitment to quality care and accessible services for over 23,000 American Indian patients. She is a proud alumna of the University of Oklahoma and holds a Bachelor of Science in Dental Hygiene and a master's degree in Healthcare Administration and Policy. Her academic prowess serves as a solid foundation for her leadership at OKCIC. And beyond her role there, Monica is also deeply involved in various community initiatives, serving as the board chair for the Oklahoma March of Dimes, fervently advocating for maternal and child health, and dedicates her expertise to the Oklahoma Dental Hygiene Association as their legislative chair, and is an active member of the National Oral Health Network Strategic Planning Committee and the Oral Health Progress and Equity Network, contributing to advancements in oral health. So I really just hope we see a highlight of Monica's deep involvement in community work. And when we get to that Q&A session, I hope you leverage her expertise and ask her your questions. So without further ado, Monica, I'll hand it over to you. Thank you for your patience.
Yes, no, thank you so much for the introduction. It's an honor to be here to speak with you guys. And we talked beforehand how it never fails that there's something that goes on in the background every time I present. And if you hear sirens, the building behind me is actually on fire, but we're fine. So it's, yeah, it never fails. So we're good in Oklahoma City, just, full of fun tricks. But I am excited to share with you guys our Integrated Dental Hygiene program. Really, yes, we are in an urban setting and area, but our patient population still struggles with access to care, with transportation. A lot of our patients do still live in rural Oklahoma and have to drive to us. So we still face a lot of barriers that are similar to those of our rural tribal facilities that we have in Oklahoma. And so this is just one step that we've taken as a collaborative with our medical programs to help just meet the needs that I feel like are consistently discussed across the nation. So if you don't mind advancing to the next slide. We know as oral health professionals that we hear this, we're starting to see more and more science come out about oral health being associated with other chronic diseases. We hear a lot about diabetes and heart disease, and how people with diabetes, for example, are more likely to have health problems, and how people with health problems are more likely to have oral health problems. So really just oral health is health, and you hear that a lot. But also oral disease is associated with risk behaviors like tobacco use, sugary foods and drinks, but then also can limit your healthier behaviors like proper nutrition and eating well. We're now seeing science showing during pregnancy that women are prone to decay and gum disease. And you go to the next slide. We're starting to see more and more data emerge on the impacts that it's having on other systemic issues that maybe you don't hear about quite as often, and specifically data showing that it's the gram-negative anaerobic pathogens that are really causing a lot of the systemic issues now coming out, like Alzheimer's disease, which is maybe not as well known as, oral health and diabetes, or osteopenia, rheumatoid arthritis. So again, those inflammatory diseases of now linking to autoimmune, or preterm and low birth weight babies. Liz mentioned before, I'm very involved with, the Oklahoma March of Dimes, and oral preterm and maternal health is a passion of mine. And so really diving into the oral systemic link associated with that has been a passion of mine, but really showing the need for that medical dental integration. The science is definitely on our side. There's more and more coming out about the linkages between oral health and health. I'll go to the next. What I feel like is interesting now is seeing the inverse of what I've just talked about, and now looking at adults that have 3 or more chronic conditions, that based on that alone, adults are more likely to have poor oral health. And so you'll see just from this study that adults that had 3 or more chronic conditions were 43% more likely to have untreated decay, compared to only 22% of adults that had less than 3 chronic conditions. So, and this was not indicative of what condition, just 3 chronic conditions or more. They're more than double the chance having untreated decay. 18% had severe gum disease as opposed to 14%. And 14% of adults with 3 or more chronic conditions had severe tooth loss, whereas only 6% of adults had severe tooth loss with 3 or less chronic conditions. And so we're starting to see just that inverse, the bidirectional impact, and how oral disease is impacting systemic health, but also systemic health may lead to worsening oral health. And then we all know as dental professionals the impacts that dental health has on oral health has on the mouth. But looking at a environment, community standpoint, 34 million, we're losing school hours. Our kiddos are missing school because of poor oral health and urgent dental care and tooth pain. So we're missing a lot of missed school hours. We're losing revenue because maybe our adults are not as being as productive as work, because maybe they are taking time off work for untreated tooth decay or oral disease, or maybe taking off work to help take care of their kiddos who are having to go to the dentist more often for unplanned or urgent dental care. 18% of working age adults are reporting that their oral health is impacting their ability to interview for a job. And so it impacts our workforce. And older adults who have low income, have less than a high school education, or are current cigarette smokers are 3 times as likely to have lost all of their teeth. And so that alone contributes to each of the 3 metrics I just spoke of, through their ability to interview and apply for jobs, workforce, and missed time from work or possibly school. So it's impacting our community as well. Next slide. So we here at the Oklahoma City Indian Clinic, we're constantly as professionals looking what can we do? Where can we make a difference? Where can we, is there any low-lying fruit? Is there any, trying to be innovative? There's only so much we can do within the 4 walls of a dental clinic. And so we always want to do more. So we started looking at this statistical data brief that was put out, and started looking at the big pieces of this pie, where are our patients going? And you see 21% didn't see medical and didn't see dental at all. So they're not accessing care at all. You see the biggest piece of this pie chart is 37% of the patients in this study did see both medical and dental, and that's fantastic. But the other big piece of the pie is 33% only saw medical, only accessed medical appointments. They weren't accessing dental at all. And we felt like that was a really big opportunity for it's, I mean, I hate to use the word captive audience, but those patients, and we looked at our statistics here, were very similar, that we had a huge portion of our patients that were accessing our clinic. They were in our building, on our campus, and we weren't seeing them. And we felt like that was a huge opportunity for us in an area that we wanted to try and target. Next slide. So that's what led us to really digging into the medical dental home model and trying that out here. So what we did is initially we did a chart review. Our dental clinic is actually right across the lobby from our women's health, our OB clinic. So we looked at there first and chart reviewed during a study period. It was like a 6-month study period. We looked retrospectively. There were 482 pregnant patients, OB patients, that were due for dental access, had a medical appointment, and we chart reviewed them. None of them received oral screenings, oral health education, any type of oral health discussion, screening access, anything during their appointment. So 100% missed opportunity. Every one of those were due for dental access and didn't get it. And so that was a punch to the gut, if you will. We're like, whew, okay, we have some easy work to do. I say easy work to do, but we had an opportunity to make a big impact here. If you'll skip to the next slide, you'll see what we started doing is using our clinical hygienists that we already had. So no additional staff, no additional anything really, and just started, you know what, if you have any time between appointments, if you have a cancellation, if you have a no-show, anything at all, if you had some time, some capacity in your day, go over there. See if there's any patients in that department right now that are due for dental access or haven't accessed our dental at all, and go see them. Let's do a screening. These are our hygienists, so let's go do a screening. Let's talk about oral health. Let's talk about anything the patient's got going on. Find out if they have a dental home. Maybe they're going somewhere else for us outside of the Indian Health Network. But at least start those conversations, and just with utilizing the staff that we had and any downtime they may have, we saw a 29% decrease in missed opportunity rate. And so making a big impact, and we were able to start merging with our our women's health and our OB providers, and start having a lot of those conversations with them, collaborating with them, talking about the oral systemic link, and really demonstrating the need and developing those relationships. And they saw too how big of a difference we were able to make with just utilizing the staff that we had, and so able to make a big difference. And so we kind of pitched this to our administration. Let us do a pilot program. If we can make this big of a difference with our OB clinic, let's do a pilot program, and let's try and see what we can do in our pediatric clinic. We'll skip to the next slide. So during the first 6 months, we did the same thing with pediatrics. We were able to see over 1,600 pediatric kiddos in the first 6 months, apply 1,931 applications of fluoride varnish, and that was including the kids in pediatrics that we did just, doing screenings on, but also in our clinic. Applied 1,600 dental sealants. And on our older kids too, starting around age 14 to 18, we'll do oral cancer screenings as well. And so we were really able to increase access for our pediatric population and continue to spread that integrated model. We started, of course, throughout our clinic, but then spreading it nationally. We've just been talking about this because with anyone that's willing to listen, I probably talk about this all day long because it's become a passion of mine, how helpful it has been. Go to the next slide. And so our current state, we've seen here just over the past 2 years, a 7% reduction in early childhood caries. We've performed over 4,000, and actually this year's numbers are not included in this for the first 6 months of this year. Nearly 4,000 screenings for 3,000 pediatric dental visits, 15% reduction in untreated decay, and over 3,000 applications of fluoride varnish. So we're really able to intercept or intervene, if you will. We're able to identify needs really early and identify patients that are coming in for the medical visits that maybe wouldn't ever access a dental department, because we also are fighting generational and family habits and history of, my mom never went to the dentist. Her mom never took her to the dentist. She's not bringing me to the dentist, and just really trying to break down some cultural norms, if you will, and have those conversations with both mom and the child while they're there during their medical appointment. So if you'll skip to the next one. So really, what is medical dental integration? And it's looking at just the whole person, the care of the whole body health. It's a patient-centered approach to really integrating and collaborating with the healthcare team and considering and getting dentistry at the table when you're talking about who is the healthcare team, and really wanting to start that bi-directional communication of the providers, the pediatric providers may be coming to you about oral health and systemic concerns, and us going to them about, if you have a diabetic patient and their blood sugar is just not getting under control, maybe we need to get the oral health evaluated. Maybe there's underlying disease. And so seeing what we can do just as a piece of that puzzle, as a tool in the toolbox to help serve the whole person. And it really is just a collaborative approach to patient care. I'll go to the next slide. We call it here, our goal is dentistry in every department. We want dentistry just everywhere. And that's what we have focused on, and we're getting there 1 year at a time. And fortunately, our administration is very supportive and see the benefit of this. We currently have 3 full-time integrated hygienists on staff that are 100% fully deployed to clinics outside of dental here on our campus. And so the impact they're making is huge, and I'll talk about each one of those here in a minute. But really, we are doing oral screenings, applying fluoride at well child checks. We're doing oral screenings and assessments of mothers at the appointment where they have a positive pregnancy test and it's confirmed. So we're starting literally at conception, well, not at conception, but at their point of positive pregnancy test. And then, just focusing a lot on education and intervention. Of course, all of our hygienists, including our clinical hygienists, we deploy anytime we can, whether it's a health fair, a community event, school activities. We do a lot of health fairs. And then our biggest intervention, I think, is the utilization of our integrated dental hygienist. So really, just the integrated dental hygiene program, again, is just our innovative approach to trying to improve the health outcomes of our population by physically implanting dental hygienists into the medical setting. The next one. So this is Abby and one of our kiddos in our pediatrics department. So that child was here for child check. And so during this, the integrated hygienist, or the I-RDH is what we call them here. She would evaluate anything from the plaque index, caries risk assessment if you can, gingival health, dental caries, presence or absence of sealants. But also you'll see here signs of bulimia and signs of abuse and neglect, things that maybe some aren't aware of, things that we can look for that can be seen in the oral cavity. And also some of the things that even we were surprised that our providers didn't realize that those were things that we look for, our medical providers here. So beneficial and more than just cavities and gingivitis is what sometimes I feel like we get put into the box of looking at. But you can see she's applying fluoride varnish. This was during the COVID era. You see that in 95. But if a family, also what I like about this is if a family is scheduling their child's first dental appointment, or maybe their first dental appointment with us, Abby, our integrated hygienist, would schedule that kiddo with her personally in clinic. So schedule herself in clinic to be that warm welcome. You already know me. You remember we met, we did this at your medical appointment, because the dental office can be scary. It's chairs that lean back, loud things coming out, your shiny stuff, and it can be scary. And so having that familiar face for their first appointment clinically allows them to do a very warm handoff of, we've already made that rapport, you trust me. introduce you to my friend who's our doctor, or my friend that's going to clean your teeth next time. It's been really, the kids just feel so much more comfortable. We can go to the next slide. And this is Bri. She started as one of our integrated dental hygienists. She's actually our dental director now. So this is her in our OB clinic, and she was doing an evaluation on a pregnant mother and doing an assessment, an oral health assessment at the time of positive pregnancy test, and then subsequently at their follow-up appointments. And the reason we do that is to really assess and tailor the education to the trimester that mom is in, and maybe the signs or the symptoms that they're having. So if it's that first trimester, maybe they're dealing with a lot of morning sickness, with nausea, and how should I take care of my teeth when I'm having morning sickness, when I'm getting sick, and there's huge opportunities there for education that we can do with moms. So then maybe as pregnancy moves forward, they're starting to have cravings. Well, what if those cravings aren't cravings that are going to be really great for the teeth? So let's start having those conversations. And then as the pregnancy progresses, nearing delivery, we can start tailoring the education to, let's start talking about how we need to care for baby. What are things we need to look for? We can start talking about maybe tongue ties, lip ties, or taking care of the gums. And there's always those cases that babies are born with teeth. Like, let's talk about all these things and start tailoring that education. You can go to the next slide. This is just a layout of the education that we discuss and what we look for at each trimester. Obviously we try to get that mom scheduled ASAP if there's anything urgent that's identified. And then routine dental care, having that appointment at the positive pregnancy test confirmation gives us the time to schedule routine dental visits during their second trimester when it's safest. Go to the next slide. Uh-oh. There we go. And so then after delivery, care is continued. The mom and baby at our clinic have their postpartum appointments together. Our doctor that delivers babies is also family medicine, so he likes to take care of the first kind of few appointments postpartum for mom and baby together, and then baby transitions to peds. But at that first postpartum appointment, our integrated hygienist is able to touch base with mom and baby, and has formed a really collaborative approach with our lactation counselors here on site. And then is also able to provide a warm handoff to the mom, or let her know what to expect. Hey, when you take baby to pediatrics, it doesn't stop there. We have a dental hygienist over there as well. And so that care just continues. And this is our newest one. And this one had a couple people raise some eyebrows, like, you're wanting to do what? We have an integrated hygienist that started full-time in our metabolic center, which is where we see some of our higher risk diabetic patients. And we know from the first few slides that that's a really a crucial spot for us to be. But also, while we're there, and I'll stop here to say, after giving this presentation and talking to people across the nation, one of the questions I constantly get is, how do you get the buy-in from the providers? How do you get that buy-in? They don't want us there. They think we're going to be in the way. They think that we will slow them down, make them run late. And this is one of the things that has been key for us, is what can we do to help them? Where are they struggling? In this clinic, they were also looking for diabetic eye disease. Right? That was one of our key quality measures, is assessing retinal health, and they were struggling with getting that done, fitting that into their appointment, or having nurses trained to do that. So, you know what? We're trying to be in there to do an oral assessment. Why can't our hygienists also be trained to do retinal imaging? Is that something we can help you with? While we're going in there, well, maybe after the nurse comes in, while they're waiting for you, maybe afterwards, if they need retinal imaging, you know what? Let us get trained on that. We can get portable retinal cameras, and if we can take x-rays, we can take pictures of an eyeball. We can do this. Like, why not? That has become our slogan. Our slogan around here is just, why not? What can we do to help? And so our integrated hygienist here now incorporates that. You know what? Let me be beneficial to you. And again, we're practicing what we're preaching about. This is whole person health. the whole approach to this is integrated health, and integrated oral health is health. So we're here, we see the value, and we're not just wanting dentistry to be part of health. We want it all to be encompassed. So what can we do to help serve this patient as a whole? So yes, we have dental hygienists that are doing retinal imaging, basically. And additionally, going back to our pediatrics team, that integrated hygienist was actually initially funded through a behavioral health grant because our pediatrics team needed assistance with ACE survey administration, so adverse childhood events, screening our families for ACEs to determine, because there's a lot of evidence on ACEs, and the higher the ACE score, the more likely you are to have chronic diseases and poor health outcomes. And so again, our integrated hygienists, you know what, let us help you with that. We can help with referrals, help provide education and resilience, resources, and again, why not? Let's be helpful. You can go to the next slide. And so you'll see these are three of our quality metrics that we look for. We measure ourselves on in Indian Health, and we report to Indian Health Services on dental access, topical fluoride, and dental sealants. And you can see in 2022, when we really deployed full-time integrated dental hygienists into our clinics, you can see just the spike in not just one measure, but all three. It was a game changer for us. And so this is where we're seeing a lot of now the reduction and areas, the improvements and outcomes. We can go to the next slide. And then again, our hygienists like it. And I asked for their feedback, like, what do you like about this? And it provides a break from just the repetitive movements, that constant chair-side skills. So they were getting some physical reprieve from having just days, because you can rotate them. They don't have to be full-time integrated. But it also provides built-in coverage in your clinic. So from a business and operational standpoint, if you have a clinical hygienist that is suddenly out or can't come in, has an emergency, you're not canceling a day of patients. We can pull an integrated hygienist over in clinic, because our patients that have scheduled appointments in clinic, we really want to honor their time and commitment of getting here, and that takes priority for us. And then they have really enjoyed becoming that part of a medical team. They're like, this feels like what we always hope for in school. You learn about being part of the whole healthcare family, but you never really feel like that when you're just in your own chair, in your own op. I really feel like I'm making a difference in this whole person and not just cleaning their teeth, right? Go to the next slide. And so we can go through these relatively quickly, but again, we're in Indian Health. We are in Oklahoma. I know every state has different rules, different laws, different levels of supervision, and state dental practice acts, but medical dental integration is everywhere. It is all on the map. So if you're not looking at it yet, I think you should. And there's so many resources of how you can implement this in different settings. This is one of them. It's the CDC initiative regarding integration, and they have a whole framework that you can, so you don't have to reinvent the wheel. So this is one option. And on the next slide, you'll see from CMS. This was actually, this is a huge push right now, is the medical dental integration and their whole centered fundamental principles that they're working on. And on the next slide, if they still have it available, I gave another presentation to them at their quality conference last year. And so sharing these results. And so again, they only had, I think, 3 dental topics, and this was one of them, which is a huge honor, because this is our goals are aligning, and that just feels great. And on the next slide, CareQuest has resources out there, the link between oral health and systemic health. And next, they have it in action. So they have links of community oral health, they have oral extended care, just a lot of resources. And I just wanted to put these out there for you guys to see. On the next slide, the ADA, of course, is now providing this is all, I feel like, more backing for ways that you can, like, hey, we're not just making stuff up and wanting bodies. Like there's evidence here. Next slide. So where do we begin? I feel like any of those that we just showed would be great places to start. Just research available resources and any evidence-based practices that are out there. There are tons. Feel free to use us as an example. You can shamelessly steal all you want. Like I will provide my contact information at the end. We are happy to share anything that may be useful. Request maybe a pilot program. Just like that's what we did. You know, give us a chance. Let's see what we can do. And if able, look into grant funding. And I mentioned briefly, that's how this all got started for us. Our first full time was, and don't just be limited, don't look just into dental. Our pediatric integrated hygienist was funded, like I mentioned, through a behavioral health grant. And our, the one in metabolic that's doing the oral, that was the oral and retinal imaging, she was funded through an optometry related grant. And so we just actually recently got some funding that was through just a cooperative with for elder adults and helping elderly adults being able to stay in their homes longer. So helping provide maybe CPAPs or you know, handrails, things like that, that we can, you know, just really help our adults stay in their homes longer. But part of that is nutrition and ability to eat, so providing dentures, things like that. So really just look outside of the box. And go to the next slide. And okay, there we go, references. And then on the very next slide, I think is my contact information. Feel free, we're going to talk about this. We're going to have some breakout sessions, maybe some time for collaboration, but there's my contact information. Feel free to reach out if you have any questions or just want to brainstorm. I'm happy to help.
Thank you so much, Monica. That was absolutely fantastic. And I'm actually going to say we can, before we go into discussion, we'll have some time for some Q&A before we head into that piece. And Sam, if you're okay pausing on sharing slides, I just invite folks to come on camera. And we're a fairly big group here today, but please just come off mute and share your questions that you have for Monica. Just dive in. And if you're having any audio issues or anything like that, you can also put something in the chat. Monica, I might dive in with a question to kick us off here, if that's okay. You know, as I said, we're going to go into discussion, and part of that is really asking folks to kind of think through their communities and what resources and pieces they have to leverage. And we typically have a wide variety of dental, public health, oral health folks on here. And it sounds like while y'all weren't necessarily leveraging medical or doing medical dental integration, your organization was set up so that was kind of a bit aligned already, especially with the proximity and starting. Do you have advice, or have you seen examples of folks who maybe are a little more disparate with their physical setting or that partnership piece? Do you have any advice there?
Yes, we actually have a rural a clinic. We call them one of our sister clinics. That's more rural, and they do a lot more physical deployment, like on mobile dental or caravans, is what we some call them here, and going out into the community, but still can be utilized the exact same way. So again, just if it is already a oral health professional that's going out, maybe again collaborating with providers beforehand to find out what can we do to look for, is there a gap that we can help provide, just to start building those relationships. But thinking on the opposite end, if it's a medical professional that's going out, see if, you know, sometimes we can collaborate and have a dental professional partner with them and go with them, or train the medical professional and ask for them and to start maybe performing an oral assessment. And so we have done both. I feel like us being there is a lot more consistent. Years ago, we had tried, and it worked well. But again, it wasn't a priority. We would train all of the nurses to apply fluoride and to, you know, do help the providers could do screenings, the nurses could do education. But, you know, when schedules are behind and, you know, we're running behind schedule, that was not the priority. And so that would be the, when their priority as a nurse and as a medical provider is to do their health, what the exam that they're there for, or what they're physically there for them. And oral assessments of fluoride would inappropriately take the back seat. But when we're there and we can be intentional and that's what we're there for, it was easier to integrate. I see a few things on the chat. This may be a great way to bring more dental hygienists back in the workforce shortage. Absolutely. With the increased responsibilities, it can entice them to be able to do more just being hopeful. Absolutely. And just, it's an option. We have one hygienist here that came out of retirement. It was like, I love what I do. I love what I can provide, but I could not do the clinical aspect anymore. She came back and she is absolutely killing it. She loves it. She's like, I feel like I'm, my passion is there and I'm just reinvigorated, basically, that hygiene doesn't have to be stuck in the op. Actually, one of the presentations I did was called Breaking Out of the Op. Like, you don't have to just be stuck there. It's something else that hygienists can do. Do the patients have the option to decline oral health service? Absolutely. Absolutely. And we always ask, and just if the patient is interested, and especially in the women's health, when a lot of the patients, maybe when they're waiting, they may be in a gown. And that's, do you want an oral screening? Now may not be the most appropriate time. You may not be comfortable with that. If you don't mind waiting longer here, we can absolutely come back afterwards, or you can decline. And that's fine. And we just document that. Patient declines, and if they're like, no, I already go somewhere else, we just note that and can create like a little flag in our system to where we don't go back in there, or we ask like, hey, just making sure you're still established. Are you still, going to see Dr. whomever? Yep, great. They're like, wow, you remember that. And so just checking back in, because as you know, things may change, circumstances may change, and we may have a patient that does see a private practice or but then things change, maybe they lose insurance, and maybe a year later they are interested. So, but absolutely, they can decline that service.
Great. Thank you all for those questions.
Great
Sam,
question.
if you're able to pull up our discussion slides real quick.
Mm-hmm.
So as we said, we're going to go into some breakout rooms here and really just giving some prompts for a discussion looking at your role, your organization, your community. What resources do you see, relationships or pathways that you can use to maybe implement an integrated hygienist program? And on the flip side of that, what resources would enable you to do that if there's a barrier?
Mm-hmm.
And what advice or questions do you have for your colleagues pursuing something similar? And we won't have time for everyone to go into all of these. If there's another thing that occurs to you, really, we want you to have some time with your colleagues in the space that may be looking at the same piece to take that information that Monica just reviewed so kindly with us and think through about your own setting and what paths forward you could take. So we're going to pop these. They're in the chat. I'm going to send us to breakout rooms. We'll come back together at about maybe 8 to the hour. We'll do a share out and we'll do our next steps as well. And there will be a staff member. Some folks will stay here in the main room. There'll be 2 breakout rooms and there'll be an I-RDH staff member in each to facilitate as well. And just a reminder to facilitators in the rooms to please record your breakout room sessions. Okay. Sam, do you mind stopping your slide share before you head to your breakout room? Thank you. And again, some of you all will be staying here with us. Monica, I think I have you here with me. Again, if that's okay, if you have time to stay with us for discussion, that would be great. And for those of you who are here again, if you're able to come on camera so we can have a good community discussion, that would be wonderful. Hi, Paula. Hi, Deborah. McAllister, you were on in video. Hey, Lisa. And Pixie. Thank you all for being here. And I think I'm still seeing folks pop out to the breakout rooms, but we have limited time. So if there's a question here, they are in the chat. If you can't see them, let me know. But I'll just let folks dive in if something occurs to you on when you're looking at your role in your organization, if you want to start there.
Hi, good afternoon. I can dive in. My name is Elisa Dack. So I was a clinical hygienist for 21 years. I took a director position for 2 health departments in Northeast Michigan. So I cover 8 counties. I'm running a new oral health program called the Kindergarten Oral Health Assessment Program. And we're going into screen preschools in the spring and then going into kindergarten. So going into schools twice a year, making sure those kiddos have a dentist and doing the full circle follow-up to be sure they have a dental home. So I'm very close to my providers as well in 8 counties. And I think that's really important too. I recently implemented fluoride varnish in our WIC clinics. And Monica, you spoke of that. You know how the nurses are doing oral health screenings and then they're doing fluoride varnish. And because I'm one person in 8 counties and I have limited funding. So until I write some more grants to get some more people on board. But one thing I've done is really connected with them. I mean, I probably connect with them at least twice a month to see how they're doing. And it's an addition and it does take back burners sometimes, but I do find that actually they're pretty excited about it. And they're seeing that total systemic care as well and the importance of it. So just staying on top of that education, staying connected with them. You know, we're working together as a team for this full person. That's worked out pretty good for our organization, and I'm hoping more to come.
That's amazing. Thank you so much for sharing that. Who else? And I will also say, please jump around. If folks want to answer the first question there, pieces of kind of what resources you can leverage, but if there's other advice you have, questions you have, if you're thinking through for your colleagues here, please jump through the questions as we go along.
Hi, everybody. I'm Deb Jacoby, and I'm the policy director at Apple Tree Dental in Minnesota. And our roots are in long-term care. And we have had for many years the dental director program where a hygienist goes out every month and assesses all of the nursing home residents, and those who choose Apple Tree as a provider, then they become patients of ours. We don't interfere if there's a relationship, you know, if they're still ambulatory and going out to their longtime dentist or whatever. But obviously the pandemic threw a wrench in everything, and in somewhat of a lemonade type of thing. It also really, I think we upped our teledentistry game. We were using it, but I think we upped it even more. And now I'm very excited about all of the minimally invasive applications and the and just, yeah, stabilization. And we have a few things with scope of practice and so on in Minnesota that need some work on them. But so I don't really have a question in this other than it's a really, and I should have said I'm an Indian Health Service alum and a very old hygienist. And so it's really exciting to me because I feel a lot like the opportunity for medical dental integration has been enhanced by necessity and by new products and new services and so on. So I really enjoyed your presentation. It just makes me feel hopeful that we'll become less about restorative and more about oral health. So thank you.
No, that's awesome. And I'm glad to hear from you, another IHS alum. And I think you hit the nail on the head. It's focusing more on prevention, but just I am hopeful of, you know, having healthcare that's less siloed. You know, that's been a goal of mine. So thank you for sharing that. I'll say too, you know, one of the things you mentioned from a policy standpoint in your state, you know, some scope of practice type things, but also one barrier for us here is just the reimbursement of working with insurance companies to see the value for reimbursement, perhaps of oral health assessments and screenings. A lot of times that is a struggle of clinics, of especially if it's a true medical practice, employing a hygienist when maybe their work may not be fully reimbursed, especially, you know, fluoride may be, but maybe not a screening or oral hygiene instruction. And so that has been a barrier, and it has been a barrier, a huge barrier for some clinics trying to get this started, is just that reimbursement.
Yeah, and maybe, I don't know if Liz would be able to speak about it more intelligently than I, but I also feel like all of the push to value-based care but we need to collect the data, have some pilots and collect the data and show the overall savings and that type of thing. So, yeah, it's
Absolutely.
a work in progress.
It is, and I feel like we're going in the right direction.
Yeah. And, oh, I thought I heard someone else and I didn't want to interrupt. Monica, that also, just when you were speaking before about some of the providers not even understanding maybe the other pieces that what a screening can show and reveal. And that just says to me some of those kind of education pieces, maybe both on the provider side and then the insurance side as well. So kind of when we're talking about policy and advocacy and kind of those big P, little P pieces, that's a little P piece to me that we can pursue with educational materials and things like this, and then continue to get the word out. Hopefully. So folks got their notice, so they should be zooming back in here over the next few seconds, but I'll also pause and see if there's anyone else from our group that wants to share anything.
Yeah, this is Pixie from Washington, and I would just say that, so I work for the Healthcare Authority, so we do the policy and we're the payers for Medicaid, and where we do have some programs that are going out into our managed care organizations and our A program and teaching the providers, the medical providers, how to apply fluoride and do oral health screenings as part of the EPSDT exam. We would like to see hygienists in those areas, but the Practice Act does not allow medical providers to supervise dental hygienists. So we're kind of in a catch-22. We find great success when we have a federally qualified health clinic that has a medical clinic and a dental clinic because they can just come from the dental clinic right into the medical clinic. But that's just one of our stumbling blocks that we've been, looking into to see how we could fix that scope issue.
Thank you, Pepsi.
Absolutely.
And welcome back, breakout rooms 1 and 2. We have a few minutes left here, and I'll just do a quick check, Sam and Annalise, if anyone from your rooms wanted to do a share out of the pieces you covered.
We didn't identify anybody. We didn't have a ton of time in our discussion, but I can really briefly reiterate that FQHCs and co-location kind of came up in our discussion, and being able to leverage integrated care just based on everything being together in one place, and recognizing that there's probably more opportunities to leverage that co-location, and an appreciation for the model that was presented.
We didn't identify anyone either, but funding came up in our conversation a lot, and we found it fascinating that Monica was able to find grant funding from other programs like optometry and pediatrics, and that was something we hadn't thought of before, but maybe something to look into in the future.
I think this is I unmuted my computer instead of my phone. I think COVID taught us a lot of lessons. And again, just why not? And you realize how you maybe don't realize until you're in there, but you're like, we can tie oral health to just about anything. And so when you're looking for funding, like the science is backing us, and it's at first, talking about that cooperative that I mentioned earlier, like how on earth are we going to tie dentures into keeping patients at home longer? But I'm like, easy. We can, tie in, nutrition. And so I think using our slogan of why not, like think outside the box, because why not? Like it really is. You can tie it to just about anything, because it is so important. And so, it's the gateway to your whole body, really. And so I think it's been easier than I thought it would be to tie into a behavioral health grant, a senior living grant, anything. So just think innovatively. Again, I'm happy to share, yes, a long-term facility, a long-term care clinic, absolutely. So if anyone wants to brainstorm, think through ideas, I'm happy to help.
Thank you so much, Monica. I think that's a good summary of the themes that came from our group as well. A lot of folks mentioned that they were hopeful with Monica's presentation. It's really exciting to see such success around medical dental integration, which I think we all know how important it is and how successful it can be. So it's great to see that model come to fruition. And we have just a few minutes left here, so I'm going to ask Sam to share our last few slides. And I'll say too, Monica, jump in and correct me if I'm wrong, but really what I was hearing from you during your presentation was an invitation for folks to use your presentation. We'll post the recording for this. We'll post the slides, which have your resources, your contact information. And so to that point of kind of pursuing outside of the box funding, using data like Monica provided us today. She also provided some piece from CareQuest, has some wonderful resources. And our resources on I-RDH, which have overlap on morality and veteran oral health. I know CareQuest tries to do this, and we try to do this of publishing data in a way that's easily usable. So when folks are pursuing those funding pipelines and those grants, look to those resources to pull those easy stats to kind of provide you a good argument and also reduce your capacity a little bit. So those tools and resources will be posted. We'll email out this group here as well as all the registrants with the email with the information. As I said at the top of the call, CEUs are available for today's session. We'll post the link for that in the chat. In just a second here, and we'll email you a reminder. There's about 48 hours to complete that request. There's also an evaluation tied to that CEU, so we use those evaluations. We're very interested in how these ECHO series are useful for you. We always want to look for upgrades, so we invite you to reply to the evaluation even if you aren't interested in a CEU today. Again, all of the resources will be posted to our website. If you have any questions, you can email our programs email, and we invite you to join us at our next session on August 22nd. We'll post the registration link to that as well in the chat. And without further ado, I'll just say thank you. I'll pause for a second, Sam. Let me see if I can grab these links real quick here and pop them in. Let's see. Okay. This is registration for our next session, maybe, and our CEU link right here. Okay, I just posted our CEU link, so folks can grab that there if they're looking for their CEU today. And I hope everyone has a wonderful day, and thank you again so much, Monica, for joining us and sharing such wonderful information. Take care, everyone.
Thank you.
Thank you guys.